Assalamu alaikum. I will speak about latest guidelines on the management of critically ill adult with COVID-19 by me, Dr. Ahmed El-Shimi, Assisting Lecturer of Critical Care Medicine, Mansoura University Hospitals. These guidelines are according Surviving Sepsis Campaign. A panel of 36 experts from 12 countries searched the literature for direct and indirect evidence on the management of COVID-19 in critically ill patients in the ICU. They identified recent systematic reviews on most questions related to supportive care and then generated these guidelines in the form of recommendation. Recommendation were either strong or weak or best practice statements. I will speak about first, I will give an introduction to COVID-19, infection control, especially for healthcare workers in the ICU, lab diagnosis, hemodynamic support, ventilator support, COVID-19 therapy. Introduction: at the end of 2019, a novel coronavirus named severe acute respiratory syndrome coronavirus 2 SARS-CoV-2 resulted in an acute respiratory illness which was epidemic in Wuhan, China. The World Health Organization then termed this illness COVID-19. This disease had become a pandemic and had affected over 2 million individuals in more than 80 countries and resulted in more than 100,000 deaths worldwide. Infection for healthcare worker performing aerosol generating procedure like intubation, like open suctioning, like pruning the patient on patient with COVID-19 in the ICU. It was recommended using fitted respirator masks like N95 respirator used in USA, FFP2 used in Europe, or equivalent, as opposed to surgical medical masks, in addition to other personal protective equipment, which was considered as one of the best practice statement. And it is recommended to perform any aerosol generating procedure on ICU patient with COVID-19 in a negative pressure room and considered as best practice statement also. While for healthcare worker providing usual care for non-ventilated COVID-19 patient, like taking the vital signs, for example, we suggest using surgical medical masks as opposed to respirator masks, in addition to other personal protective equipment, for sure. And this was considered as weak recommendation. For healthcare workers who are performing non-aerosol generating procedure but on mechanically ventilated patient, using surgical medical masks as opposed to respirator masks was recommended. Weak recommendation also. For healthcare worker performing endotracheal intubation on patients with COVID-19, video guided laryngoscope over direct laryngoscope proved more benefit. For COVID-19 patient requiring endotracheal intubation, the endotracheal intubation must be done by the senior or the healthcare worker who is most experienced in airway management to minimize the risk of transmission and is considered as one of the best practice statements. Lab diagnosis and specimen. After COVID-19 being pandemic, every critically ill patient arriving at the hospital with any evidence of respiratory infection should be considered potentially infected. Real-time PCR is still the gold standard for diagnosis. The problem is COVID-19 has an extended incubation period, about 2 weeks, which includes a prolonged interval of viral shedding prior to the onset of symptoms, which reaches about 5 days. The duration also variable with the anatomical site of infection, upper respiratory tract infection versus lower respiratory tract infection. For intubated and mechanically ventilated adult with suspicion of COVID-19, lower samples are preferred to upper respiratory tract samples like nasopharyngeal or oropharyngeal swabs for diagnostic testing. With regard to lower respiratory samples, we suggest obtaining endotracheal preferred to bronchial wash or BAL, bronchoalveolar lavage, which is considered as a weak recommendation to consider. In a study accounting for CT scan finding among suspected COVID-19 cases in comparison between CT and the PCR, 48% with negative oropharyngeal swab or nasal swab were considered highly likely cases by CT. So, a single negative swab from the upper airway doesn't rule out COVID 19 infection, and repeated sampling from other multiple sites, including the lower airway, will increase the diagnostic yield. A single positive swab confirms the diagnosis of COVID 19 and is enough to trigger infection control precautions in your place and appropriate treatment of the patient. Regarding hemodynamic, Chinese study of 1099 patients with COVID-19 with similar severity of illness found that 1.1 percentage developed shock. In hospitalized patients, the incidence is likely higher, may reach up to 35% among patients in the ICU. Cardiac injury also has been reported in 7% up to 23% of patients with COVID-19 in Wuhan, China. Still, studies on risk factors still lacking, but old age, patient with comorbidities, CKD, liver cell failure are more risky and more have higher risk for shock and cardiac injury. On assessment of COVID-19 shocked patient in ICU, dynamic parameters like skin temperature, capillary refilling time, or serum lactate measurement preferred over static parameter like measuring CVB, urine output, in order to assess fluid responsiveness for acute resuscitation of adult with COVID-19 and developed shock. Conservative over liberal fluid strategy is recommended, and crystalloid over colloid. On resuscitation of an adult with COVID-19 and developed shock, balanced crystalloid over unbalanced crystalloid recommended if available. Hydroxyethyl starches very recommended. Gelatines are not recommended, and the dextrans and the albumin not recommended for the resuscitation of COVID-19 shocked patients. Regarding vasopressor, on management of COVID-19 shocked patient, they may need vasoactive agent. The first line as vasoactive agent to be kept in your mind is norepinephrine. If norepinephrine is not available, we can use vasopressin or epinephrine, but keep in mind vasopressin causes digital ischemia and the epinephrine causes high lactate level and some arrhythmia. Dopamine is not recommended. Adding vasopressin as a second line agent over titrating norepinephrine dose if target mean arterial blood pressure, which is about 60 to 65 millimeter mercury, can't be achieved by norepinephrine alone. For COVID-19 shocked patient, titrating the vasoactive agent to reach mean arterial pressure of 60 to 65 millimeter mercury would be better than higher targets. For shocked patient with any evidence of cardiac dysfunction and the persistent hypoperfusion despite fluid resuscitation and norepinephrine, dobutamine would be the best choice in this case. In case of refractory shock, low dose steroid can be used over no corticosteroid therapy with the same dose of low dose steroid in refractory septic shock, which is 200 milligram in divided dose. Regarding ventilator support, starting supplemental oxygen if the saturation becomes less than 92% with weak recommendation. but some papers suggest starting supplemental oxygen less than 90 percentage with a strong recommendation. In acute hypoxic COVID-19 patient, the target saturation should be no more than 96 percentage. If a patient is still hypoxic despite the conventional therapy, high flow nasal cannula is recommended over a conventional therapy. In this, high flow nasal cannula is recommended over non-invasive positive pressure ventilation like CPAP or BiPAP in acute management of acute hypoxia in COVID-19 patient. But if high flow nasal cannula is not available and there is no urgent indication for intubation, a trial of non-invasive positive pressure ventilation with close monitoring and short interval assessment for upcoming worsening of respiratory failure. Helmet over mask non-invasive positive pressure ventilation is an option, but with lack of evidence in COVID-19. Close monitoring for worsening of respiratory status, like the patient becomes tachypnic, acute hypoxia, hypercapnic, hemodynamically unstable. Early intubation is one of the best practice statements in treatment. Regarding invasive mechanical ventilation, in case of mechanically ventilated adults with COVID-19 and developed ARDS, we can use low tidal volume. Low tidal volume ventilation is the best choice in this case. At tidal volume 4 up to 8 milliliter per kg predicted body weight with a strong recommendation, with targeting plateau pressure less than 30 centimeter water, and the higher beep strategy is preferred than lower beep. Means beep at 10 centimeter water preferable than beep at 5 or 4 centimeter water in mechanically ventilated adults with COVID-19 and the moderate to severe ARDS according to Berlin grading. In case of COVID-19 patient and ARDS, as we said before, conservative strategy over liberal fluid strategy is more preferred, even if COVID-19 patient on mechanical ventilator. For mechanically ventilated adult with COVID-19 and they developed moderate to severe ARDS, prone ventilation for 12 to 16 hours is recommended. Sometimes in ICU we may need neuromuscular blocking agent to facilitate patient ventilator synchrony, but we prefer in case of COVID-19 patient intermittent boluses over continuous infusion to facilitate protective lung ventilation. In case of dyssynchrony between the patient and the ventilator, a continuous neuromuscular blocking agent infusion for up to 2 days is recommended with weak recommendation. Inhaled nitric oxide has no role in COVID-19 ARDS patient with strong recommendation. In severe ARDS patient and still not responding despite optimizing ventilation, a trial of inhaled pulmonary vasodilator as a rescue therapy can be used, but if no rapid improvement in oxygenation, this treatment should be tapered off. Recruitment maneuver can be used in COVID-19 ARDS patient despite optimizing ventilation, but staircase incremental PEEP recruitment maneuvers are not recommended. In ventilated adults with refractory hypoxemia, despite optimizing ventilation, use of rescue therapy, proning position, all your trials failed, we can refer the patient then to an ECMO center if available with weak recommendation. What about COVID-19 therapy? It has been reported that there is an association between COVID-19 and the cytokine storm syndrome, which is a hyperinflammatory state characterized by fulminant multi-organ failure like myocarditis seen in some cases, acute liver failure with elevation of cytokine levels in blood. In mechanically ventilated non-ARDS adult, routine use of corticosteroid is not recommended, while ARDS adult using systemic steroid is preferable than not using steroid. In ventilated patient, empiric antimicrobial or antibacterial agent is recommended, but keep in mind the duration of treatment, your culture results, and proper descalation. For critically ill adult who develop fever, paracetamol is the best choice for temperature control. In critically ill with COVID-19, IVIG is not recommended. In critically ill adult with COVID-19, routine use of convalescent plasma is no longer recommended, as we have no evidence about the antibody titer required for those critically ill adult with COVID-19, plus increased risk of transmission of diseases. Routine use of lopinavir and ritonavir in treatment of critically ill adults with COVID-19 is not recommended. No evidence about recombinant interferons alone or in combination with antiviral in critically ill patient. Insufficient evidence for use of chloroquine or hydroxychloroquine in critically ill COVID-19 patient, and also insufficient evidence for use of tocilizumab, which blocks interleukin 6 in treatment of COVID-19 critically ill patients. Thank you.